Good afternoon, everyone, and a warm welcome to today's discussion on the HOPE campaign, Hodgkin Lymphoma Awareness, presented by ETHealthworld. I am Pratibha Raju, Senior Assistant Editor at ETHealthworld, and I'll be your host for this insightful session. The webinar marks the second edition of our three-part series where expert doctors will address lymphoma, a critical and growing health concern. As the most common form of blood cancer, lymphoma affects the lymphatic system, an essential part of our immune defense. With the rising incidence of the disease in India, raising awareness has become more crucial than ever. Lymphoma is broadly categorized into two types, Hodgkin and non-Hodgkin, which are leading contributors to cancer-related deaths worldwide. Today, we are privileged to have renowned experts joining us, sharing their insights on non-Hodgkin lymphoma, including its diagnosis, treatment, and the vital importance of early detection. Now, let me quickly introduce you to our esteemed panelists who bring a wealth of knowledge and experience on this discussion. So we have Dr. P. Prabhu, who's a senior consultant hematologist, hematology oncologist associated with Apollo Main Hospital, Chennai. Thanks a lot, Dr. Prabhu, for joining in.
Thank you.
Yeah. Next, we have Dr. Narendra Thota, who is a head of the department and consultant hemato-oncologist and stem cell, BMT, bone marrow transplant specialist associated with the Krishna Institute of Medical Sciences in Hyderabad. Thanks, Dr. Thota, for joining in. So next we have Dr. Mangesh P. Kamath, who is an additional director medical oncology, hemato-oncologist, and blood and bone marrow transplant physician, Fortis CG Road, Bangalore. Thanks a lot, Dr. Kamath, for joining in.
Thank you, Pratibha.
And we have Dr. Chepsi Philip, who's a professor and program director, adult and child hematology, bone marrow transplant at Believers Church Medical College and Hospital, Tiruvalla, Kerala. Thanks a lot, Dr. Philip, for joining in. So we have representatives from the whole of South India joining in. What else we would need? So I would quickly go into the panel discussion. So let me start with the basic question. So I would go to Dr. Prabhu first. What is lymphoma?
Okay. Lymphoma is cancer that involves lymph nodes mainly. So in our body, we've got lymph nodes in various parts of the body. In the neck, they're called cervical lymph nodes. In the axilla, they're called axillary lymph nodes. There are lymph nodes distributed throughout our body. A cancer that arises in lymph node is called lymphoma. So there are certain there are white cells in our blood, and there are certain specialized type of white cells called lymphocytes. They circulate in the blood. They also reside in various organs, including in these lymph nodes. When there is a cancerous multiplication of these lymphocytes within the lymph node, they result in enlargement of these lymph nodes. And usually that is a situation that we refer to as lymphoma.
Thanks a lot, Dr. Prabhu, for briefly explaining. So so we have the basics. We know what is lymphoma. So quickly to Dr. Kamath, how do we identify the signs and symptoms of Hodgkin lymphoma? If you can talk about that.
So as Dr. Prabhu said, lymphoma is the disease of the lymph nodes in our body. So whenever you have any swelling of the lymph nodes, whether it is the neck, it is the armpit, or any other part of the body, that could be lymphoma, not necessarily. It's very important to know that the most common cause of lymph node swelling in our body, in our country, is usually tuberculosis. So we have to be extremely careful about that. So if there is a painful swelling of the lymph nodes in any of these externally palpable areas, most likely it is a lymphoma. Along with lymphoma, if it's the disease of the lymph nodes, you get certain symptoms which we call as constitutional symptoms, which could be in the form of fever, which can occur either once in a day or multiple times in a day. And that could be associated with drenching night sweats. I mean, you get sweating in the evening and your clothes are drenched with the sweat. You could be having weight loss, which is without any reason, with no intention of losing weight. In the last 6 months, you tend to get weight loss. And then itching, fatigue, many other these non-specific symptoms which make it difficult for you to not consult a doctor.
So now we know what is lymphoma and the signs and the symptoms. I would like to go to Dr. Philip. Could you kindly elaborate on one of the subtypes of Hodgkin lymphoma for the audience, please?
Yeah, Pratibha. Of lymphomas, one of the types is Hodgkin's lymphoma, which, like Dr. Mangesh typically said earlier, is usually detected when you have a swelling noted by the patient somewhere, and then we go ahead with the biopsy, and the biopsy will confirm the diagnosis of lymphoma. And in the lymphoma, the commoner type is the non-Hodgkin's lymphoma, but Hodgkin's lymphoma is a variant of the lymphoma, which further is divided based on the morphology and the IHC. We usually classify them into two types. We either divide them as a classical Hodgkin's lymphoma or a rarer type, the nodular lymphocyte predominant Hodgkin's lymphoma. This is the gross different types of Hodgkin's lymphoma, and within the classical Hodgkin's, you have your nodular sclerosis type, which is the more commoner of the type, and these are all subtypes within these two broad entities.
Thanks a lot, Dr. Philip, for that explanation there. And I would like to go to Dr. Tota here. How do you access patients diagnosed with Hodgkin lymphoma?
So basically, it is all about the clinical presentation, which my colleagues has said about those things. So whenever a patient comes to a clinician, they'll be presenting with the lymph node enlargement or like these symptoms which the other doctor has explained. So whenever you see these patients, obviously you get a suspicion that you are going to deal with some form of lymphoma. And sometimes, as the other colleague said, it could be infection also. Sometimes, in India, should be very careful about evaluating tuberculosis also. So whenever you see these patients, clinical examination has to be done. So when you palpate these patients, you'll get the sense that you're dealing with the lymphoma, because the consistency of the lymphocytes and the sites which they generally appear in the body, they give a clinical clue for us. So along with that, the symptoms, most of them, they have sometimes atypical symptoms like itching. Sometimes patients who are alcoholics, they have alcohol sensitivity, insensitivity. And these are these abnormal symptoms, and the classical lymphoma symptoms also there, like weight loss, drenching sweat. Sometimes patients present saying that they have excessive sweating, which the clothes also drops. These are very clinically important features. Whenever we see a patient that we think that they are very highly suggestive of lymphoma patients. So these patients, obviously, the first thing what we do is clinical examination followed by lymph node biopsy, which is very important part of the investigation. Along with this, we do the routine investigations like blood investigations. Then we do the scans. And once the lymphoma is confirmed based on the biopsy, pathologist helps us in classifying these patients into Hodgkin's and non-Hodgkin's based on the IHC. We call it as it's a technique which helps in classifying the lymphomas into broadly two categories. Again, within Hodgkin's lymphoma, there are again different varieties. So once the lymphoma is confirmed, then what we look at is we look at the staging work. We want to know whether it is in the early stages or it's the advanced stage. So for that, there are a set of investigations like PET-CT scan, which is very important, especially when we are dealing with the lymphomas. Then we'll be doing, based on the necessity, bone marrow aspiration and biopsy. And we do certain investigations to give chemotherapy, whether they're fit enough to take the routinely advised regular IUD protocols, which we use routinely in this patient. So these are the set of investigations we look at for the staging, whether they're fit enough to take the treatment or not. So these are all investigations we routinely do in our practice to diagnose the patient.
Okay, thanks a lot, doctor. Now I would like to go to Dr. Prabhu again and ask, how do we diagnose Hodgkin lymphoma?
Okay.
If you have further added points, if you can just.
Okay. In terms of diagnosis, I think both my colleagues just told you what are the typical symptoms of Hodgkin's lymphoma. Just to emphasize again, typically patients with Hodgkin's lymphoma will present with lymph node enlargement in any part of the body. Most of the time, it's easily visible. It can be a lump in the neck or armpit, and you do a biopsy from there. So a diagnosis of lymphoma is done by histopathology, meaning you have to take a biopsy and send it for, histopathological examination. And there are certain specialized tests done in the biopsy which will confirm the presence of Hodgkin's lymphoma. That is the initial step in diagnosis. Once it is diagnosed, like many other cancers, we actually do what is called staging. We want to know whether a patient has got early stage or advanced stage. Hodgkin's lymphoma is classified as stage 1, 2, 3, 4. Early stage is generally stage 1 and 2, and the advanced stage is stage 3 and 4. The way this staging is done is by using radiological methods, CT scan, and right now in Hodgkin's lymphoma, most patients will undergo PET-CT, which will actually tell us the extent of the disease. So if you have early disease, it will be just confined to one part of the body. Whereas if you have advanced disease, you'll have multiple lymph node enlargement, which is seen and sometimes inside the chest and abdomen. And in advanced disease, it would be widespread. And sometimes, rarely, this lymphoma can also occur in non-lymph nodes, outside the lymph nodes, like in liver, spleen, and various other organs. So when we think about lymphoma, the first thing to do is a biopsy and then a staging. After we stage, we decide whether the patient has got early stage or late stage disease. Based on that, we would use the most appropriate treatment modality.
Thanks a lot, doctor. It was like nicely explained. It was really nice. So let's ask about the risk factors. Quickly going to Dr. Philip, what are the risk factors for Hodgkin lymphoma?
Yeah, so just continuing with that discussion. So there are no clearly defined risk factors for Hodgkin's lymphoma, but now we recognize that there are certain factors which are associated with that higher incidence. So we recognize that there is a familial factors which are associated with increased incidence. There are exposure to viruses which have been postulated as factors which might increase the incidence of Hodgkin's, and then immune suppression per se, having immunodeficiency, immune suppressive drugs as a treatment in the past are all known factors which are associated with increased risk of Hodgkin's disease. So in terms of familial incidence, what we understand or what we recognize is that in twins, and then if you have your same-sex siblings, the risk of Hodgkin's lymphoma appears to be as high as 10-fold than those with different gender siblings and those who are not twins. So that is something that gives us a clue as to having a familial risk. And then but we've not still identified any genetic factor which has identified it, but this association is known. And beyond this, we also recognize that certain viral infections can have a proactive role in developing Hodgkin's lymphoma, particularly viruses like that we call it as Epstein-Barr virus. So we recognize that infections with an EB virus has an increased risk of having Hodgkin's lymphoma. On one hand, when we have this increases with EB virus, there are also reports which suggest a negative or a protective effect of other viruses like, say, chickenpox, measles, mumps, rubella, in having a negative role in the incidence of Hodgkin's lymphoma. Then, like I told you earlier about immune deficiency. So we recognize that diseases like the immunodeficiency, like HIV infection, or people who have received other immunosuppressive drugs in the past, or who have an abnormal immune response to their diseases, are at higher chances of developing Hodgkin's lymphoma. So even though research is on and we are still yet to identify the exact genetic switch which ticks off Hodgkin's lymphoma, these are the recognized factors which play or increase the risk of developing Hodgkin's.
Thanks a lot, Dr. Philip, for that, listing out the risk factors there. So I would like to go to Dr. Kamit. Can Hodgkin lymphoma be prevented? I think this will be a crucial question, which is like going on in certain patients' mind also. So over to you, doctor.
So my answer to this is in continuation with my colleague, Dr. Philip. So in most cases, we don't know what causes Hodgkin's lymphoma. There are other kinds of lymphomas for which we know certain causes. There are certain viruses like hepatitis B virus and many other bacteria are also known to cause certain lymphomas. But when it comes to Hodgkin's lymphoma, we believe that there is a virus called Epstein-Barr virus, which is implicated for being a part of the pathogenesis of the Hodgkin's lymphoma. That means that is the virus which is known to cause some mutations in the lymph nodes, and that causes Hodgkin's lymphoma. But there are certain other factors which can actually accelerate or probably increase the risk of formation of Hodgkin's lymphoma, that is HIV infection, and certain conditions where a patient is taking steroids or certain immunosuppressive drugs for other issues like joint pains, rheumatoid arthritis, or autoimmune diseases. So if you really want to get the answer for how it can be prevented, well, if somebody is infected with HIV, they should routinely undergo evaluation or seek immediate medical attention if they develop any swelling of the lymph nodes. That's point number one. And how to prevent HIV? I think we need not go into it. So if you can prevent HIV, you'll prevent a lot of diseases, and lymphoma is one of them. Now, with regards to other things, there is a lot of information that's coming up that Hodgkin's lymphoma is also very common in low socio-economic conditions. So, especially those people who are living in the non-hygienic conditions, or there where there is a lot of infections with viruses such as Epstein-Barr viruses, there is a high clustering of Hodgkin's lymphoma that is seen. It is also seen in certain countries where in cold weather, where the virus kind of spreads much faster compared to the very warm countries. But if you look at it, there is a lot of socioeconomic ways of preventing it. Obviously, preventing immunosuppressive infections such as HIV, and it is also important for us to know that whatever happens, even there is some data to say that developing TB can also increase your risk of having Hodgkin's lymphoma. In fact, when we actually do the biopsy, many a times we find Hodgkin's lymphoma, and along with that, we even find tuberculosis as well. So these are some things that we need to know, that there is probably some sort of an interplay between viral and these difficult to get rid of bacterial infections such as tuberculosis.
Thanks a lot, Doctor. Now, to move on, I would like to go to Dr. Narendra Tota. What is the prognosis in patients who are diagnosed with Hodgkin lymphoma?
Prognostication, all the tests which we have discussed before, we use them. So these tests helps us in staging these patients. As we said, they are different stages, 4 stages, 1, 2, 3, 4. So we club especially stage 1, stage 2 into early stage. Again, in this 1 and 2 also, we categorize into favorable and unfavorable based on certain features. So again, stage 3, stage 4, we consider as that as advanced stage. So these patients, obviously, as the lymphoma, if it is in the early stage, you expect to be doing well. So the patients who are in the late stages, obviously, it's a general understanding that they don't do well. So within these stages also, we have certain markers, like, if the patients have B symptoms in early stages, if they have a very big mediastinal mass, that is a big tumor mass within the chest, which is considered as a poor prognostic marker. And any lymphoma, generally we see in the lymph nodes, right? So any lymphoma which is presenting in beyond the lymph nodes, like extranodal, we use the term as extranodal. If these are the sites is involved, and we use one more blood test like ESR. It's used to classify these patients, especially in advanced phase, early phases, categorize these subset into favorable and unfavorable patients. So along these markers which we use early stage, in the advanced stage also, we look at the blood cells like WBC and other markers to classify these patients into early stage, advanced. Within these two categories, based on the prognostic, like the set markers, we classify into high risk and low risk. So these are things which we use routinely in practice to classify into different categories so that we can prognosticate the patients. Suppose these patients fit into early stage, favorable, or we expect their survival to be near to 90 to 95%. And we are saying about the cure rates. What we are saying is cure rates. Suppose if the patients are advanced stage with all bad prognostic markers, also, even then, we expect the survival rate somewhere like 30 to 40%. This is the only cancer among all the cancers in our bodies which are still curable, even in advanced stage. So I have quite a few number of patients, even in stage 4, they are curable, and there are patients who are surviving beyond 4 to 5 years. So for us to say a lymphoma is cured, we generally cut off the duration of around 5 years. So patients who survive beyond 5 years, we generally assume they are cured. So these are the markers and stages which helps to counsel the patients, saying that about their prognosis.
Thank you, Dr. Narendra Tota. Let's move on to the next question. I would like to go to Dr. Prabhu again. How do you decide to treat Hodgkin lymphoma patients?
In Hodgkin's lymphoma, generally, almost all patients get treatment because, see, as Dr. Tota Narendra Kumar said, there are two broad categories of Hodgkin's lymphoma from a staging point of view. You got early stage disease, you got advanced disease. Just like Dr. Narendra Kumar said, I have to emphasize that even in advanced stage disease, one can actually aim to cure the disease. How do we decide to treat? See, in certain low-grade lymphomas, we often take an approach of wait and watch without treatment. Whereas in Hodgkin's lymphoma, in most situations, in more than 90% of cases, you would decide to treat. If it is early stage disease, sometimes, just with a bit of chemotherapy and radiotherapy, you can actually provide cure to the patient. In advanced stage disease, you will involve combination chemotherapy. There are many different kinds of combination chemotherapy which one uses. And we also right now use a monoclonal antibody, a more targeted treatment specifically against one antigen that the lymphoma cells express. So in Hodgkin's lymphoma, the decision to treat is straightforward. You stage, and in almost all patients, you decide to treat. The reason to explain this clearly is because in some of the public who are listening to this webinar might have come across certain lymphomas where we decide not to treat and wait and watch. But it's not the case with Hodgkin's lymphoma, where whether it's early stage disease or advanced disease, there is a high chance of achieving good remission, which often translates into cure. So most patients we would take for treatment. When I say most, then is there a type of Hodgkin's lymphoma where you won't treat? There's a very rare variant of Hodgkin's lymphoma called nodular lymphocyte predominant Hodgkin's lymphoma, where they are usually present with a little lump in the neck or armpit, which has been there for years and years, and then they come and see us. We do a biopsy and we diagnose this rare variant of Hodgkin's lymphoma, where sometimes we would decide, okay, you had a surgery, there is no other lymph nodes, you might just wait and watch. But in all other situations in Hodgkin's lymphoma, you decide to treat. Whether once you have a diagnosis, whether you have symptoms or not, you decide to treat.
Thanks a lot, Dr. Prabhu. Now we know how, what makes you all to decide to treat. Let me go to Dr. Philip to know how is Hodgkin lymphoma treated?
Yeah, I think Dr. Prabhu has already elucidated that it has to be treated. That is what we usually do. And actually, Dr. Kumar had already talked about the staging and the favorable and the unfavorable or early types. So that is how we actually make a plan on what to treat the patient with. So in practice, the dominant factors which make us decide on the initial therapy are one, like Dr. Prabhu said, there is a particular type NLPHL where you might just decide on a wait and watch strategy, or if surgical excision has been done, you might just observe the patient and see if treatment is needed. So one of the factors is the histology of the disease. So whether it is a classical Hodgkin's lymphoma or an NLPHL type. Another factor which helps us decide the type and course of treatment is your anatomical stage. Like earlier already mentioned, whether it is favorable risk, whether it is stage 1 or 2, or advanced disease, whether it is stage 3 or 4. And favorable risk, some centers might have follow certain criteria laid by a particular group known as EORTC. Some of the centers might follow a particular criteria laid by the German group. But whatever it is, it only shows you whether it is an aggressive type or a less aggressive type to decide on the type of treatment. And these are basically the prognostic factors. So like already mentioned, ESRs, the size of the lymph nodal mass or a mediastinal mass, the dimensions of it. So that is another factor, the presence or absence of poor prognostic factors. Then bulky disease, like I already told you, more than 10 centimeters in size of a particular mass. These are all factors which tell us what is the course of treatment to be taken. So the choice of the intention to treat is always yes, go ahead and treat. Very rarely that we wait and watch. And once we've decided to treat, these are the kind of factors which help us determine the course of the treatment. So at least in this current practice, most standard of care in most of the institutions is to have treatment strategies based on this particular criteria that I mentioned, where we usually divide patients into early stage disease with favorable prognostic factors or early stage disease with unfavorable or poor prognostic factors. And then we have a particular category, which is the advanced stage. So based on this, the usual centers will decide on the duration of the chemotherapy course. So like if the centers usually practice ABVD in majority of the centers in India, but there are also centers which adopt combination chemo. So it's usually going to be a combination chemotherapy approach. The most commonly one used is ABVD in our country. Then we also have certain institutes which follow the BCOP regimen. But whatever it is, they first divide them into early stage favorable, early stage poor prognosis, and then advanced stage. And this is done because, as a general rule, what we do is early stage diseases, we try and use this combination chemotherapy with fewer number of cycles and use radiotherapy to consolidate whatever remainder part of treatment that you require. That is what we try and do with early stage disease. While those in advanced stage disease, we usually treat with a full course of chemotherapy, usually 6 cycles of chemotherapy. And the role of radiation therapy is only if there is a bulky mass, but otherwise radiation therapy is not usually favored in advanced stage disease. And then you have a different dosing of your radiotherapy in favorable and unfavorable early risk disease. So that's how we usually go about treatment. And nowadays we also have this, like already mentioned, we have this antibodies, you have this immunotherapy coming up in terms of anti-PD-1 antibodies and brentuximab, which are now getting integrated into standard chemotherapy. But I think that it is safe to say that in India, currently the first line of therapy still remains following your chemotherapy backbone, plus or minus radiotherapy, depending upon the intensity of the disease, whether it is early or advanced, favorable or poor prognosis.
Thanks a lot, Dr. Philip. Well explained. It was elucidated properly. So now we know how is Hodgkin lymphoma treated. I would like to go to Dr. Kamit. How do patients, long-time survivors of Hodgkin lymphoma, adapt to the situation of having had a life-threatening disease and undergoing treatment? Again, a very important question. Dr. Kamit.
Something that I would like to emphasize to my audience here is that Hodgkin's lymphoma is considered as one of the top 10 curable cancers that are known today. It is, in fact, one of the earliest examples of cancers being curable. In fact, a lot of history is there, which has actually helped us, develop so many protocols and so many concepts in the treatment of cancer. And so, when we have a cancer which is as curable as Hodgkin's lymphoma, it is now very obvious that we have a huge number of survivors who have survived Hodgkin's lymphoma with the successive treatment protocols that was elucidated by all my co-panelists. So this has not been happening for the last 1 year or 2 years. It has been happening since the last 3 or 4 decades. So that's how successful all of us have been with respect to management of Hodgkin's lymphoma. But now what's emerging is that while we are able to cure upwards of 70 to 80% of all Hodgkin's lymphomas, there is that issue of the repercussions of the treatment that we are giving to our patients. So a lot of the treatment that we are giving is through chemotherapy. Now slowly we are having targeted therapy in the horizon, and that is being given to those patients with advanced Hodgkin's lymphoma. So the ones who have been treated with multi chemotherapy regimen, there are certain side effects that we are seeing, and that is extremely important. Now, side effects can be acute side effects, that is side effects that occur during treatment, or those that can occur after the treatment has been completed. We call it as late toxicity of treatment. And this is causing a lot of issues for many of the patients. And as many of us know, Hodgkin's lymphoma affects a lot of adolescents and young adults. And that is why when they get into their 40s and 50s, some of them seem to develop some really concerning late toxicities. Some of them could be toxicities involving the heart. Some of them involve the toxicity in their endocrine system, due to which they are unable to bear children. So the sterility and thyroid diseases are extremely common. Some of them develop certain musculoskeletal issues. Some of them develop psychosocial distress. They have been thinking about Hodgkin's lymphoma since their teens and adolescents, and then that kind of makes them extremely, distressed over a long period, and hence they are not able to perform in family as well as at work. And then there is this big threat of having second malignancies or second cancers. So some of these treatment that we have given to these Hodgkin's lymphoma patients can damage the DNA and cause the emergence of second cancers such as blood cancers and so on. And that can also develop after maybe 1 or 2 decades of completion of treatment. So the having known all this information, we have to clearly have a discussion with all our Hodgkin's lymphoma treatment after they have completed the treatment, that look, these are some of the issues that are seen in a few patients who have completed the treatment for Hodgkin's lymphoma. You need to be aware of it, and you need to be in close follow-up with us. We understand that you are excited and really happy that we have been able to achieve success. However, this success has got a few riders with this. Second malignancies can occur. You may develop some other issues. So whenever you develop any symptoms related to these issues, please come back to us without delay, because there are a lot of treatment strategies available so that we do not make a mountain out of the small moles. Now, why I say that is, there are certain issues, if you treat them early, they will not concern the patients. But if they are not treated early, they can cause death due to these late toxicities. So identification of these late complications early enough and managing them early enough will help us to decrease the morbidity which can occur in many of these patients. And sometimes, if we are able to detect it really early, we can even cure those second toxicities in many of these patients. So please make sure that we have a discussion with all our Hodgkin's lymphoma patients as to what they could expect even after their Hodgkin's lymphoma is cured.
Thanks a lot, Dr. Kamath. Well said. Yes, a lot of awareness is also needed, and that's why I think this webinar is very crucial. Crucial, so it goes to the right audience. So now, going to the next question, I would like to bring in Dr. Narendra Tota. This is a specific question, again a very important question. How do you address fertility and sexual health during treatment and follow-up care?
So whenever a family or the patient who gets a diagnosis who get a cancer, and we explain that they are going to require be treated with the chemotherapy. So obviously everybody knows that chemotherapy has got side effects, and the first question when they explain these things to be treated to the family, that they ask the immediate side effects. Like my colleague has explained all the side effects, which is immediate side effects, long-term side effects, everything. But the most important thing the family asks next thing is about the fertility, especially if they are kids like pre-pubertal, that is if the boys are adolescent or children. And the next category is post-pubertal and young adults, somewhere who is above 18 years, puberty when they attain the puberty, and somewhere the age between 18 to 30 or 40 years. And this is the age where the fertility issue is very important. And this is the age most of the people get married and they look for the pregnancies. And it is the same concern is with the males and females also. So when we see such a patients, then we obviously counsel the family that there will be a fertility issue. But the most important thing here we have to understand is the fertility issue is not that real fearsome if you compare with the other treatments of malignancies, because when we treat the patients with chemotherapy, we categorize these cancer chemotherapy drugs into 3 categories. The categories where we use, there is 80% or more than 80% possibility of infertility. They are very high intensive treatments, like the drugs which we use, especially in bone marrow transplants, and when we do a radiation for the patients when we are taking up for the transplant, where the chances of infertility is very high. But again, the second category is intermediate type. The risk zone is only in between 20 to 80%. And there is one more group, the less than 20% risk of infertility. So the good thing about the Hodgkin's disease is the drugs which we use, especially for Hodgkin's lymphoma, they come under the category of low risk. So that's the good part about the treatment. So most of the patients have that fear that they may have infertility, but so there is a chance of infertility, but this is very less. Nobody should be really scared about the treatment. And obviously, if you don't want to take a risk of this, even 20% of infertility risk, there are procedures where we can help the families with the help of our infertility colleagues. I think most of the centers will be having this, and even outside centers, a lot of centers are offering this. Suppose if I'm dealing a female patients, if she's young and recently married, who don't have kids, which is very sensitive matter for the family. So first, we'll explain the risk. There is only 20% chance. If you are okay, we'll go ahead. Some patients, they don't even like the chance even to take that 20% risk of chance. So then we offer these patients, we actually refer these patients to our colleagues in infertility department. So what they offer to these patients is, they do a ovarian stimulation for 2 weeks, because these patients can be postponed their treatment for more than 3 weeks, because this only rarely they are emergency type of cases where we need to treat them immediately. So we get a time that 3 to 4 weeks is there. So with the help of our infertility colleagues, we can retrieve a ova from the patients, and you can store them. You can cryo-freeze them for next 10 years. So suppose patients who are already married, if there is a spouse who can donate the sperms, they can create an embryo and they can store the embryos also for future purposes. But I think for females, just saving a ova should be fine. And for males, just storing the semen should be fine for the future fertility they want to bear the children. Especially the problem comes when the patients are pre-pubertal, when they don't attain the puberty. So here you can't do much, but the present technologies which are available in a few centers in India, what you can do is, you can do a testicular tissue extraction, which is in very few centers in India, they offer this, and you can store that in a cryo-freeze like -170 centigrade for future purpose. So these are all the techniques which helps in preventing the infertility problems after getting treated. So this is how we counsel the families. So most important point here to understand is, this is not a dreadsome that you're going to have 100% infertility. It's hardly 20% infertility. And even if you don't want to take a risk at all, there are definitely procedures with the help of our colleagues, gynecology colleagues. You can store the semen in males, and you can store the ova or embryos in females. So that's a very important part where we counsel all my patients whenever we see in our office.
Thanks a lot for explaining it so well. I think a lot of patients will be informed by your, answer. So let me go to the next question. I would want to pose this question to Dr. Kamit. What proportion of lymphoma survivors know about the risk of late effects that might be increased by the treatment period?
Let's know a few things that are occurring in the field of Hodgkin's lymphoma. So I was talking to you about these long-term survivors of Hodgkin's lymphoma in your previous question. So a lot of treatment changes have occurred. We are actually now going into the era where we are trying to be minimalistic with our treatment for patients. We are avoiding certain drugs in certain scenarios. In fact, there is something called as de-escalation of treatment and escalation of treatment depending on interim PET CTs that we do during the treatment of Hodgkin's lymphoma and so on and so forth. So at the end of the day, a very small percentage of patients who are treated and are cured experienced a relapse or return of the cancer after they have been seemingly cured. A very small percentage of patients will develop late toxicities. When we talked about heart and toxicity, sterility, and all those things, we were not talking about 20 and 30% of all the treated patients. We were talking about single digit percentages. Some of them may be 2%, one or some of them may be 3%, and so on and so forth. But it has to be understood very clearly that medicine works on trying to eliminate all the issues that could be associated with the treatment of diseases. So for a doctor and for my colleagues, even 2 or 3% is extremely important, and we try to emphasize that to our patients, saying that it is seen in a really small percentage of our patients, but if these symptoms occur in you, you could be one of them, and we can definitely manage that effectively. That is the way of communication that we have to give, because if we do not emphasize that a really small percentage of patients develop a relapse, a small percentage, they will think that, oh, my chances of getting back the lymphoma is more than 30, 40, or even 50%. That is not the truth. So it's very important for us to know that because of our minimalistic treatment, because of our evidence-based effective treatment, and because of our investigations and our extreme careful management of these patients, the chances of relapse are minimal. The chances of developing lot of these organ toxicities are also minimal. So it's very important that patients realize that. If as a doctor I'm able to put it into my patient's mind that the patient has to be in touch with me at least for the next 1 or 2 decades after the completion of treatment, and also give them certain strategies for reducing the risk of developing these so-called late effects, I would have done a wonderful job. Because if the patient is aware that after completion of my chemotherapy I still have to be in touch with the doctor, that means the patient likes the doctor in one way, and that the doctor has effectively communicated the same. So it's very important that we tell them. So to just summarize, first point, single digit percentage is there of patients developing a recurrence of cancer. Single digit percentage is there of patients developing late organ toxicities. Single digit percentage of developing secondary cancers, and less than probably single digit percentage of those who will die late, maybe because of the effects of the treatment. So this is something that I would like to emphasize to all the lymphoma survivors.
Thanks a lot, Dr. Kamath, for summarizing it. Let me go to Dr. Narendra Tota for the next question. How can we lower the risk of Hodgkin lymphoma progressing or coming back?
That's a question asked by every family. Actually, there is no clear-cut answer. To prevent a lymphoma, there is nothing we can do extra. As the colleague who has explained all the causes like HIV, EBV infections, there are basic etiologies. Only what you can prevent is have a safe sexual protective life. That's the only thing which can be used to prevent a future lymphomas, because of the HIV they have an immunocompromised status where they can get the lymphomas. But other than that, which is nothing in our hands. But what we can advise the families is healthy lifestyle, which is advised for every patient, whether they are the lymphoma patient, if they are the cardiac patient, or the neurological patient, any patient. What we advise is the same thing, like good diet, regular exercise, maintaining good sleep, stress-free environment, all these things which looks very simple. When we say these things to the patient, they take it very lightly. Nobody want to follow it up. But these are the things which gives tremendous amount of immunity to the patient. And probably if you follow these things very carefully, probably these are the best things to avoid future recurrences also. Simplest, not expensive, everybody can follow, but nobody will follow. So these are the things which we can advise in our all lymphoma patients.
Thanks a lot, Dr. Tota. Yeah, no one listens to doctors, isn't it? So let me go to Dr. Philip. How do you plan the long-term monitoring of Hodgkin lymphoma patients?
I think all my previous colleagues have already spoken in detail about the curative impact of the treatments available, and the fact that because you have such cures, there is a potential possibility of seeing, even if it is in single digits, you see these complications of treatments coming in, the potential chances of relapse, even though very minimal, still these are the ones that exist. So at least immediately following therapy, I think there are no late guidelines, but like we recognize that up to 5 years you have an high incidence of relapse. I think most of the institutes follow this close follow-up for 5 years, of which at least in our center, for the first 6 months, we follow them up every month. And then for the next 2 years, we follow them between 3 to 6 months, depending upon their proximity to a location. And then up to 5 years, we usually follow them up every 6 months. I think more or less most of the centers would follow an immediate follow-up like that. That is primarily to identify risk of relapse. And then beyond that, usually it is more about educating the patient that they have this higher chances of secondary malignancies that exist, and make them sensitized to the fact that if they develop any symptom, to reach out to a specialist nearby. That is something I think the primary primary person who is treating that lymphoma patient should inform that family that after 5 years it's not all over, but then that is this time when you might have the onset of the the later effects, the non-relapse kind of effects. So one thing that we really need to highlight is the fact of secondary malignancies, and inform the patient that there are certain screening guidelines that are available and that you stick to them. So you have your breast cancer screening guidelines that they have to adhere to. Be particularly aware of it. We do your annual screenings that are advised. Colorectal cancers. So whatever screening risk is, guidelines exist in the country. These patients should be aware, because many a times beyond 5 years, our follow-up is limited to the same center because they might be very far off. So then at least if they sensitize, they will go to a nearby place to at least get it screened. They won't let it be because they've had a malignancy in the past. They'll be very anxious and they will report it at the earliest. Then another factor that they should be aware is that because of the multiple treatments that they've received, you have this cardiovascular risk factors which are high. So any effort intolerance, any symptoms that suggest towards a cardiac risk, also the patient should report. So even though in our center we don't have a system for beyond 5 years follow-up, but we give them an information that if you develop these symptoms, at least once in 5 years, get your echo done. If you're beyond 40 years of age, we advise them that for breast cancers, we advise them to get your annual mammograms done. So these are general advice. We are not following them up, but this is the advice that we give them. And I think one of my colleagues already told you about the infertility issues. So that is also informed to them, but luckily, because that is how treatment for Hodgkin's has evolved, that we have tried to risk stratify the patients based on favorable, unfavorable, early and advanced disease. We've reduced the treatment intensity so that we provide as much cure as possible with least toxic effects. So all that is hopefully that the incidence of all those complications are going low and low, but it is informed to the patients that because you have these risk factors, if you are attempting to it, then you need to seek out the help of your infertility specialist. So these are all advices that we give. So 5-year strategy is kind of defined and almost clearly followed in most institutes. But beyond that, I think it is primarily relies on the advice that the primary physician who has treated them gives to them, that beyond 5 years, this is what we have to look at. And I would emphasize that we need to stress the fact that secondary cancers and cardiovascular, and sometimes you also get this pulmonary complication later, which could be also based on symptoms. If you can identify them faster, then your chances of having a very good quality of life, even if you're affected with that complication, is very realistic. So I think there are no guidance as such, at least in institutes in India. There might be follow-up criteria based on NCCN, but primarily in India, I think 5 years good follow-up continues, and beyond that, based on the symptoms, which the patient is adequately sensitized to to follow up with the respective symptom-based experts.
Thanks a lot, Dr. Philip. You have actually elaborated and gave a good full-fledged answer to it. Let me quickly go to Dr. Prabhu. What are the patient-perceived communication barriers and facilitators at different stages after the diagnosis of lymphoma? Yeah.
So in terms of barriers, when you first see a patient, usually in Hodgkin's lymphoma, it tends to be young patients. Firstly, in terms of, when they've come to see you, they've come to see you with what initially looks like innocuous symptoms, like just a lymph node enlargement, fever, weight loss. No one comes to see us expecting a diagnosis of lymphoma. So when you first mention that, we need a biopsy, or we mention that the patient has got lymphoma, there is initially a situation where, the patient is shocked and wasn't expecting this diagnosis. That in itself creates a temporary barrier in terms of communication. When a doctor says to a patient who otherwise thinks is well and just comes in thinking that he's got just a prolonged viral syndrome, and once you mention the word lymphoma, there's initially the first thing that happens to the patient is there's disbelief, and they cannot accept that they've got a type of cancer. That in itself causes a barrier in terms of communication. Once they don't accept that particular situation, it's very difficult to communicate further. So that barrier is usually overcome with a lot of patience and understanding. You understand that that it's going to take a period of time for the particular individual and the family to come to terms with the fact that they've got lymphoma. That initial barrier is overcome by just giving people some time to process the information and calling them back to further explain. So that is the initial kind of barrier that one experiences, and that you just overcome by just giving time. Giving time for the patient and the family to come to terms with the fact that they have now a new challenge to deal with. Subsequently, the other things that we see with the patients are the families, once you inform them that they've got a type of cancer, is the first response from most people is, well, I've lived a life of, hardly any bad habits within inverted commas. I've not got any risk factor. I don't have family history of cancer. So why did I get it? So the next communication that we have to do effectively is to communicate to them that the fact that they've got lymphoma is not their fault. Very often when you communicate to a patient or a family that someone has got cancer, there's immediately a bit of soul searching to say, oh, I probably didn't do this right. I probably smoked. I probably had alcohol, or several such things. They go through a guilt trip. Maybe that is the reason I have got this cancer. And sometimes families, especially with Hodgkin's, we are dealing with young adolescents, and the parents go through a guilt trip thinking that, look, maybe I didn't look after them well. Maybe the last time they had a viral infection, it was lymphoma, and I didn't look after them. So all these kind of issues arise. And that is generally overcome by, repeatedly telling them that the fact that you got lymphoma is not your fault. Although we have, my colleagues talked about risk factors and viruses and things like that, lymphoma, Hodgkin's lymphoma especially, is one cancer whose incidence in a particular individual no one has control over. Of course, there are viral infections like EBV, etc., but there's nothing that you can control. It just happens within, that's how it is. So you need to talk to the patient and family to first take away that feeling of guilt that, because of something they didn't do well, that they got this cancer. And subsequently, once they've come to terms with the fact that, they've got a cancer, then that's the time to approach to them with good kind of survival statistics. Thankfully, we are discussing a cancer where most patients, definitely almost all patients, go into a good remission unless they are a very advanced disease in an elderly. Most patients have great response to initial treatment. So you're dealing with a cancer where most patients have positive outcomes. So that needs to be emphasized. And once that is emphasized and you talk about various modalities of treatment, the next immediate kind of communication challenge comes. When you talk about chemotherapy, to young adolescents, either boys or girls, it causes a huge interruption in their social life, in their educational activity. So that is another challenge. I remember sometimes when you have young adult patients with Hodgkin's disease, when you tell them, to restrict certain activities, the first thing they ask for is all very simple. When can I go out and play with my cousins? When can I go out and have food in fast food joints, things like that. So such very simple activities get restricted. So you need to communicate to them that, there is a period of time you're going to have treatment. And during that time, you have to be very careful. And the other thing you have to do is to communicate side effects clearly, so that they have a realistic idea of what chemotherapy causes to them. Like my colleagues were saying, recent advances have meant that, we have succeeded in reducing the intensity of chemotherapy in patients with good risk disease. We've kind of tailored therapy based on risk. So the number of side effects one anticipates, especially with a commonly used chemotherapeutic regimen like ABVD, is not as bad as many types of cancers where we give chemotherapy. So you need to communicate side effects very clearly. And the need for follow-up and all these things. These things can be, in India, mostly it's the doctor-patient, but of course in the West, you've got a lot of facilitators and counselors, but we do use counselors. And these have to be effectively communicated. And when you're doing that, you have to communicate about side effects, need for follow-up. Like my colleague, Dr. Philip, was saying, very important to emphasize on long-term follow-up, because many of these young adults are exposed to various risks, in future, like second cancers, coronary artery disease. So I always emphasize to these young patients with Hodgkin's disease that you have to avoid accumulating risk factors, maintain a good weight, don't smoke, don't drink, etc. So there are various, in patient's journey, there are several points where effective communication is important, and it is quite a challenge.
Thanks a lot, Dr. Prabhu. You had summarized it so well for us. And that was my last question to the panel. So as we conclude today's webinar, I would like to extend my heartfelt thanks to all the panelists for their valuable time and expertise. Your insights have undoubtedly enriched our understanding of Hodgkin lymphoma, covering crucial aspects such as awareness, early detection, and treatment options. We appreciate your commitment to advancing knowledge in this important area of healthcare. Thanks a lot for that. And to the audience, thank you for joining us and for your engagement throughout the session. We hope you found the discussion informative and empowering. Please remember to share the knowledge you have gained today and continue to raise awareness about lymphoma in your communities. Stay tuned for our next session in this series and have a great day.